one thing we spend money on various sleeping things because we're everything else is
Okay, thank you everybody for your patience. Sorry for the technical difficulties. Welcome to our breakfast with WACh. We're really thrilled to have you all here and to have our tremendous speakers today who are from the Enterics for Global Health study, and they are among the many rising stars in this Enterics study. So next slide. So just some background on the underlying study that is drawn from for the projects that you're going to hear about today. The background of the study is really focused on Shigella diarrhea. Shigella is an important bacterial cause of diarrhea, but it's the second leading cause of diarrhea. Yeah, we might just want to make it. Might just be also. Okay.
Yeah, the mic.
Yeah, I can hear.
You can hear me. Okay. The British can hear the loud American. Perfect. Okay. And Shigella is estimated to cause about 60,000 child deaths per year. This number increases to 80,000 if you account for the fact that Shigella is also on a pathway towards a child developing stunting, which segues to the next bullet point. Shigella is associated with linear growth failure, both its diarrhea causing consequences, but also just the infection itself, even in the absence of diarrhea, which has long-term morbidity implications and is associated with decreased vaccine efficacy. And there are several promising Shigella vaccines in the pipeline. Next slide. So the EFGH study had two goals. The first was to generate up-to-date Shigella burden data, specifically prevalence and incidence, and consequence and cost data from 7 countries known to be high burden settings for Shigella diarrhea. And it also had the secondary goal, which was to prepare clinical trial sites for eventual phase 3 vaccine trials. And that includes harmonizing clinical management and laboratory methods, training and capacity building, and infrastructure maintenance and development. Next slide. So the study takes place in 4 countries and is supported by investigators around the world, including here at the University of Washington. Next slide. I am going to hand it over to Kirk Kel to talk about the Rising Stars program nested in EFGH. Over to you, Kirk.
Hi, thanks, Paddy. I think the first thing I wanted to say is that EFGH is a consortium, both from the kind of the PI leadership level, but also from the funder, has really emphasized a lot of the kind of principles of decolonization that we've wanted to see in global health research for a while. And part of that commitment was to support junior investigators from all of the sites to kind of achieve the next step on their career. And so the Gates Foundation was kind enough to fund a Rising Star program, which mirrors the WACh Rising Star program. And this comes along with many of the other initiatives within EFGH, like the manuscript writing cohort and just the kind of basic consensus-based decision-making that has happened in EFGH. So to tell you a little bit more about the Rising Stars, next slide, that's the one. So the kind of the core of the program is seed funding. So $20,000 to $30,000 worth of seed funding to do data collection and data analysis on a topic of the awardee's choice. We received many applications from all of the sites. It was very competitive and there were lots of great applications. We've so far been able to do 2 cycles. A third one is just starting. So this seminar really represents the culmination of the second cycle. So in addition to the funding that was awarded, we felt it was really important to try to extend some of the benefits that many of us enjoy as part of being UW, like our online library resources, our access to data support, and just the kind of mentorship and networking that we're able to get. So we tried to roll that into the program as well, largely through this kind of non-residential affiliate scientist position, which allowed for access to some of our online resources that we are all lucky to have. So if we jump to the next slide. So we're going to hear today from our three rising stars in the second round, Naveed, Jane, and Maureen. And I'll just say, personally, it's been a real pleasure working with each and every one of them, and really excited to see their results today. So I think that's probably enough from us. Maybe we can hand it over to the presenters. Thank you.
First up, we have Naveed. So Naveed, go ahead and share your screen.
Thank you, everyone. Thank you, Patty and Kirk, for setting up the stage, and everyone for providing me this opportunity to present my work to this relevant audience. So my project is on an introduction of vaccine and routine immunization program Pakistan using a case study of Shigella vaccine. And we did this stakeholder analysis. And I am Naveed Ahmed from Khan University Hospital, Karachi, Pakistan, and I work as a research manager here. And I have been part of EFGH Phase B throughout these 2 years, and I've been coordinating activities from Pakistan side. And it has been privileged to work with this UW coordination team and other stakeholders and other sites as well. So, yeah. So starting with the background, diarrhea remains leading cause of morbidity and mortality under 5 years of age, and Shigella is among the top bacterial cause of moderate to severe diarrhea among children, and especially prevalent in areas with poor wash practices. Water and sanitation hygiene practices. And Shigella is developing resistance to commonly used antibiotics, and this also increases the urgency for preventive measures like vaccination. And there are multiple Shigella vaccine candidates are in advanced stage of clinical trials, and introduction is maybe on the horizon, and it's becoming a realistic, future possibility. So why did we do this study? We wanted to, taking this opportunity, we wanted to understand the stakeholders inside, and we thought that it would be crucial to capture the real world scenario, and for ensuring that Shigella vaccine, once it is available, is introduced efficiently and equitably into the EPI program of Pakistan. So this is why we did this study. And so before I move forward, I would like to present some overview of routine immunization in Pakistan. So the National Immunization Program Pakistan is backed up by the WHO and Gavi, and it offers 12 routine vaccines targeting major childhood illnesses, which includes polio, measles, diphtheria, and hepatitis B, and so on. And Pakistan has an experience and infrastructure to introduce new vaccine, and which is reflected in the recent successful introductions, like typhoid conjugate vaccine in 2019 and rotavirus 2018, which shows readiness for new vaccines. And however, it needs strong political commitment and planning to tackle persistent challenges, which includes coverage disparities and vaccine hesitancy and logistic constraints and critical consideration for future vaccine rollouts, which can be considered as a critical consideration for future vaccine rollout like Shigella vaccine. So how did we do this study? We used a qualitative expertise study design using GDs and with caregivers for children who with age under 5. And we conducted in-depth interviews with key stakeholders to explore perception around diarrheal diseases and vaccine implementation. And data was collected through semi-structured interviews in local language, which is Urdu. And we recorded these interviews with the consent from the participants, and we translated and we back translated as part of the quality assurance component of the study. And we did a thematic analysis using consensual qualitative approach to identify key themes and categories. So this is the overview of participants. We try to focus on main stakeholders and we included parents and caregivers, those who are carrying the children under 5 years of age, those who are eligible for the vaccine, future vaccine if it is introduced. And we also included the stakeholders, which includes community and religious leaders and healthcare providers, which includes pediatricians mostly, and program managers from the API program, and also Federal Director of Immunization, which is a main stakeholder in making the decisions for new introduction of the vaccines. And also we involved Ministry of Health and Ministry of Education, which is Ministry of Education, which is mainly focused mainly helpful during the catch-up campaigns and mass immunization campaigns. So coming to the key findings, we use a healthy model to frame our findings, which help us to understand what drives or hinders vaccine uptake for Shigella prevention. And the model looks at how people perceive disease risk, vaccine benefits, and barriers to action. So we found out that caregivers perceive diarrhea as a frequent issue, especially due to poor water and sanitation. And the Shigella, though not always well understood, but after giving the presentation, it is considered as a serious issue when we explain the participants and the risk of this disease like dehydration and hospitalization. And also the vaccines, the perceived benefits were the vaccines are generally seen as positive, and they are believed to strengthen immunity. And many parents' confidence is shaped up by the previous vaccine experiences and seeing their children staying healthy afterwards. So that's why they opt for the vaccine. And the perceived barriers were like fear of side effects, misinformation, and practical issues like access or scheduling, etc. And the triggers that motivate parents include messaging on TV and door-to-door campaigns and trusted advice from healthcare providers or religious leaders, which it also really triggers and motivates the parents to take the vaccine. And self-efficacy, parents feel more capable and confident when the system supports them, like reminders for the vaccine, clear schedule, and community trust in the program. So these insights show us that readiness for a new vaccine like Shigella not only rely on awareness, but also on trust, support, and how the message is delivered. Tailored community center strategies and essential. And so moving forward, so these are the other issues that that influence the health belief model. So the importance of healthcare from these are the perspectives from the policy makers and other stakeholders. And for the health belief model in health belief model, we try to fit in the findings that are coming from the focus group discussion that were conducted from the parents. So the policymakers, the point of view is Shigella is underreported due to diagnostic challenges and And while it can be severe, many perceive it as a self-limiting and leading to mixed views on the urgency. So there is a need for stronger local data to guide the decisions. And as for the vaccine characteristics, stakeholders discuss preferences for oral versus injectable formats and number of doses, overlap with the existing diarrhea vaccines, and vaccine fatigues are relevant concerns. And other vaccines are also being prioritized. So the timing of this introduction of this Shigella vaccine would be really important. So moving to the financial and economic considerations, so the Gavi is the main is a strong incentive. Many countries act quickly when the funding is available. In Pakistan, so the Gavi funding is mainly provided for the introduction of the vaccine. So and therefore the vaccine pricing isn't a major issue, but the currently government of Pakistan is working with Gavi on a 60-40 model. 60% is paid through Gavi funding and 40% is paid through government of Pakistan. So once the Gavi pulls out its funding, so sustainability of the EPI program and other vaccine is in question. And the acceptability of Pakistan is a system in place to manage hesitancy and implement new vaccines, and key stakeholders, including technical, financial, and advocacy partners, are supportive of new introductions. As I mentioned, that the driving force is the funding. So yeah. So one slide. Yeah. So the stakeholders emphasize that the consideration of other alternative interventions like water and sanitation and hygiene practices in preventing the diarrheal diseases rather than focusing on the vaccine. They also focused on strengthening the program of WACh practice and WACh practices. And so any vaccine introduction must consider the cost effectiveness compared to or alongside these non-vaccine interventions. And decision-making process is, introduction discussions are evidence-driven always, and especially on disease burden and vaccine impact. So the data from national surveillance must align with the external sources like WHO, Gavi, or the surveillance data that we are collecting as part of the EFGH. It should synchronize with the data of the government of Pakistan, so that the decision can be made. And the key actors involved in the decision making are the people are from various departments like EPI, Ministry of Health. WHO is also main key stakeholder in introduction of the vaccine, and Gavi. And we have this National Immunization Technical Advisory Group, NITAG, which is also a steering committee, steers the decision on the vaccines, and like professional bodies like pediatric associations and others as well. And external triggers like Gavi calls disease outbreaks, or calls the calls for the expression for the vaccine introduction. And there are disease outbreaks and regional uptakes like the neighboring countries, including introducing the new vaccine. So it can also impact the introduction of new vaccines. And also the academic lobbying and visibly in WHO-led forums also push the agenda forward. So in conclusion, this is probably the last slide of my presentation. And so in conclusion, Shigella is underreported due to diagnostic limitations and weak surveillance, even though diarrheal diseases are widespread among children. And so this leads to low perceived urgency despite its long-term health impacts. And vaccine decision makers and caregivers consider oral versus injectable dosage schedule and the presence of other diarrheal vaccines like rotavirus in the current EBI program that could be conflicting. And the financial sustainability is Gavi's support is critical for initial rollout, but there are concerns about the long-term sustainability, as I mentioned. if the Gavi pulls out of this EPI funding. And the decision-making process is always complex and requires high-quality local data, government commitment, and collaboration with global partners like WHO, Gavi, and national like EPI, FDI, and NITEC. These are the main actors. Could play a major role. And the triggers include the disease outbreak, global recommendations, and regional trends as well. These could also trigger the introduction of a new vaccine. So in the last, but not the least, I would like to acknowledge my mentors, Dr. Farhanas Kamar and Dr. Tahir Yusufzai for their eternal support, and also Kirk and Sonia for their guidance and throughout guidance, and Ariana, who helped me a lot developing the questionnaires for this this study, and Gates Foundation, and most importantly, my study participants. Thank you so much for your attention.
Thank you so much, Naveed, for that excellent presentation. It's very important qualitative work that done. So it's very exciting. We are going to hold off on questions until the end so that we ensure all three presenters get through their presentations. But if you have a question, feel free to pop it in the chat so that presenters can read and maybe respond as we go. And then at the end, we'll take verbal questions.
Yeah, sure, thank you. So should I stop sharing my screen?
Yes, please. Thank you, Naveed.
Thank you.
Okay. Next we have Jane. If she needs to accept this invitation. Jane, if you see a pop-up on your screen to accept the invitation to be a panelist, please click that. Then you'll be able to screen share. Jane, please accept the invitation so that you can screen share. I apologize, this webinar format. Best idea. Perhaps we should go to Maureen and then, yeah. Maureen, are you able to screen share and go next?
Yeah, sure.
Thank you. Jane, again, I need you closed.
Maureen, are you able to share your screen? There we go. Perfect. Thanks.
Right. Hi, everyone. Thank you so much for the opportunity to present to this group. So my name is Maureen Ndalama, and I am a pharmacist by training, and I'm currently working as a study coordinator with the Malawi Liverpool Wellcome research program. So the title of my Rising Star project was Understanding Healthcare Treatment Practices of Caregivers of Under 5 Children with Diarrhea at Ndlama in Malawi. And my supervisors for this project are Dr. Jennifer Koenig, who's the PI for the EFGH site here in Malawi, and also Dr. Thomasina O'Brien, who's based at the Malawi Liverpool Wellcome research program. So I'll start off with a bit of background. Diarrhea remains a leading cause of death among children under 5 years of age, particularly in low middle income countries. And from the map, you can see that the percentage of deaths from diarrhea disease among children under the age of 5 is very high in the African continent. And if you can see, Malawi is somewhere there, and it's also quite high. Treatment options for diarrhea recommended by the World Health Organization include rehydration with oral rehydration salts. Zinc supplements are also recommended to reduce the duration of a diarrhea episode. Nutrient-rich foods, including breastfeeding during episodes, and also a balanced diet, particularly exclusive breastfeeding for the first 6 months of life, are essential to break the cycle of malnutrition and also diarrhea. Antibiotics are reserved for specific cases such as bloody diarrhea, also known as dysentery, suspected cholera, or severe infections. However, despite these guidelines, inappropriate use of antibiotics remains widespread in many low and middle income countries, including Malawi, contributing to antimicrobial resistance. In 2019, out of 4.95 million individuals who succumbed to drug-resistant infections worldwide, a staggering 1.27 million deaths were directly attributed to antimicrobial resistance. And alarmingly, 1 in every 5 of these fatalities affected children under 5 years of age. So as you can see on the graph, on the map, the African continent, the mortality due to antimicrobial resistance is very high. One of the primary drivers of antimicrobial resistance is the misuse and overuse of antimicrobial drugs, including antibiotics. So I'll not bore you with the aim of the Enterics for Global Health, Shigella surveillance study, but my project was embedded in the EFGH study, and we noted that in Malawi, the study was conducted at Ndlama Health Center, and we noted that during participant recruitment, there was significant variations in caregiver treatment practices for diarrhea, and this was prior to seeking care at the facility. So we also noted that in the healthcare utilization survey, where participants were asked if they sought care at any health facility, and if they did not, they were asked what actions they took, and we saw that most of them reported using antibiotics such as metronidazole and amoxicillin, or some of them just said that they had medication in the house that they used from a previous prescription, or they were given some medication from a neighbor. So the use of antibiotics by caregivers without a prescription raises concerns about their knowledge and decision-making regarding the treatment of diarrhea in children under 5 years of age.
Maureen, can I just interrupt for 1 second? We're seeing black boxes on the right. I don't know if you're seeing this from your side, so I wondered if you could get rid of your chat box. It's just blocking some of the screen, or you could try resharing, or looks like you had your cursor on the,
is that okay?
That's better, but we still see another box on your bottom right, a big box.
A big, okay. Let me try and reshare maybe.
That would be great.
Yeah.
If it doesn't work, we will make it work, because your narration, we should be listening to you anyways and not reading the slides, I suppose.
Is that any better?
Yes, perfect. Thank you.
Great. My apologies for that. So my objective was to understand and explore factors influencing caregiver treatment practices for diarrhea in children under 5 years of age, and also to develop targeted interventions that promote awareness on the appropriate use of antibiotics. I had 2 specific objectives, and these were to explore caregivers' knowledge and perceptions of treatment practices for children and also to identify the health care-seeking behaviors of the caregivers. So in terms of the methods, this was a qualitative case study. The study population were caregivers of children that were enrolled in the EFGH study. So I recruited from the diarrhea case surveillance study as well as the healthcare utilization survey. So for the diarrhea case surveillance study, I recruited caregivers that had sought care in the health center and reported prior healthcare seeking by administering an antibiotic before bringing the child to the health facility. And from the healthcare utilization survey, I recruited the caregivers that reported not seeking care at the health facility, but opted to give the child an antibiotic that they either bought at a drugstore, pharmacist, or they administered antibiotics that were available in the household. So the study site was there in the health center, and my sample size was 30 caregivers. So I conducted semi-structured interviews using a topic guide that was developed. I also used what is called a drug bag method, and this involves showing physical samples of antibiotics to encourage conversations about recognition, use, as well as accessibility. Most caregivers are not familiar with the names of drugs, so I use the drug bag method to initiate conversations on the drugs that they know or they're able to recognize, or the drugs that they've been able to use. So this slide explains the steps that I took to implement the drug bag method. So the drug bag method has been used previously at Malawi Wellcome Trust. The first thing that I did was to scope around Ndlama and the health center, as well as different pharmacies for the antibiotics that are available. And I bought the antibiotics. Then I assembled them and numbered the antibiotics. And then later I prepared a power sorting exercise, which involved asking the caregivers to put aside the drugs that they have recognized, that they've used before, or they've heard before. And then I would ask them which ones they have frequently used, which ones they have used to treat diarrhea. So the last picture just shows the exercise being done by a caregiver. The data analysis was conducted in parallel with the data collection, and I used a recording device to record the interviews, which took about 30 to 40 minutes. And these interviews were transcribed by a team at the Malawi Wellcome Trust, the translation department. Field notes were used to complement the transcriptions, and the transcripts were then uploaded into NVivo, and themes were identified. Because the objectives were slightly different from the main EFGH protocol, I had to write up a protocol and submit it to the ethics committee for approval, and it was approved. And I also had to develop an informed consent, a separate informed consent, which was shared with the participants. And for individuals who are unable to read or write, the consent form was read aloud in the presence of a witness, and they provided their consent by printing the form. And because these were participants that were being recruited in the EFGH study, I had to reimburse them for their time because they had spent a lot of time at the answering the interview questions. For the results, this graph shows the findings from the drug bag exercise. So I noted that the antibiotics that the caregivers were able to easily recognize from the drug bag were amoxicillin, erythromycin, doxycycline, and also cotrimoxazole. And when asked which antibiotics they had given the child during a diarrhea episode, you can see that metronidazole was the drug that was commonly given. And in total, I conducted 27 interviews. From the diarrhea case surveillance study, I recruited 11 caregivers, and from the healthcare utilization survey, I recruited 16 caregivers. So I initially planned to do 30 interviews, but when I reached 27, I noted that I had reached data saturation. So therefore, I stopped at 27 interviews. So in terms of the factors that were influencing the caregiver treatment practices, we saw that knowledge on causes, signs and symptoms of diarrhea was one of the factors influencing them. Caregivers were able to identify the causes of diarrhea, and they were able to mention contaminated food, unsafe water, poor hygiene, and unsanitary living conditions. However, some of the caregivers were linking diarrhea with teething, and also caregivers were able to identify some of the severe symptoms for diarrhea and were able to respond. One of the caregivers mentioned that what I know is that sometimes the child develops diarrhea during teething stage and sometimes have diarrhea due to an allergy after taking water from certain sources. So like I mentioned about teething, some were linking diarrhea to teething. Another factor that was influencing the treatment practices was knowledge on diarrhea treatment. So some caregivers had adequate knowledge on what to give. They were able to easily say that they gave the child ORS and zinc. However, some caregivers did not have adequate knowledge and mentioned either giving zinc or ORS or an antibiotic to treat diarrhea. And one of the caregivers mentioned that usually I decide on which drug to give the child first by giving her zinc and then later switching to metronidazole after observing no improvement. So they would try out either zinc or ORS and then move on to giving an antibiotic, but not give them in combination. Another factor that was influencing the treatment practices were drug shortages at the hospital. So caregivers reported frustration with stockouts, therefore pushing them to seek care at other places and not at the health facility. And social networks significantly contributed to medication access and support during illnesses. Some caregivers mentioned that because of the stockouts at the health facility, their neighbors would share them antibiotics and they would use what the neighbor shared them. And another important factor that came out was a lack of trust in the prescription written at the health facility. So some caregivers demonstrated that regarding the accuracy and completeness of a prescription, there were concerns that the doctor would be overworked and sometimes may miss to include an antibiotic. So a quotation from one of the caregivers was that sometimes the doctors may be disturbed and miss including a certain drug in the prescription since they attend to many patients. When we find out that the child's condition isn't improving, we decide to give metronidazole. So despite a doctor being a gatekeeper of antibiotics and ensuring that they only prescribe maybe zinc or ORS, a caregiver would still go ahead and buy an antibiotic because they feel that it was missed in the prescription. So discussion, caregivers understood common causes of diarrhea, but often linked it to teething, reflecting misconceptions. Antibiotics like metronidazole and moxilin were frequently used without prescriptions, often sourced from informal channels. There's also a low confidence in clinicians and a strong community network influencing caregivers to bypass medical advice and share antibiotics. So in terms of the limitation, the sample size was drawn from a single urban township, which may limit the generalizability of findings to other urban or rural areas in Malawi. And also all respondents were mothers. Therefore, the exclusion of fathers or other caregivers may have left out key perspectives on household decision-making. And also reported data is subject to recall bias and also social desirability bias, particularly regarding the use of antibiotics and informal treatments. So the next steps for my project, I would like to conduct a workshop with different key stakeholders for the initiation of dialogue on developing targeted interventions that promote awareness on the appropriate use of antibiotics. Lastly, I would like to acknowledge the following people who have been very key in helping me with this project. Thank you very much.
Thanks so much, Maureen. That was a great presentation. Another example of excellent and important qualitative. We will now move on to our final presenter. So again, please hold your questions till the end. Jane, go ahead and share your screen.
Thank you, Sonia. Thank you, everyone, for your patience. I had some hiccups earlier. Okay, so thank you for finding time to attend to this talk on association between gut microbiome and Shigella incidence in children below the age of 5 in Mali. Shigella invades and colonizes the intestinal epithelium, leading to disruption of the intestinal barrier and the gut microbiome. Delayed or impaired reconstitution of the microbiome follow infection by enteric pathogens such as Shigella can further impact overall health. Children with severe illness tend to have a less diverse microbiome and a predominance of specific genera of organisms. We hypothesize that infection with Shigella results in a microbiome profile that is less diverse compared to infection with other pathogens. We will characterize the gut microbiome in Shigella infected and non-infected children enrolled in the Enterics for Global Health Shigella surveillance study in Mali. We will investigate whether the presence of certain bacterial communities in the gut is associated with Shigella incidence. So this is a nested study within EFGH study in Bamako, Mali, and this is just a small map of Mali and the areas where the study took place. It is not a good one, you know, but next time I think I'll have a better one. So under methodology, I would like to describe briefly on EFGH Shigella surveillance study, which was a multi-site study conducted in 7 countries, Mali being one of them, and the protocol is described elsewhere. A total of 1,400 children between the age of 6 to 35 months who had medically attended diarrhea were enrolled with the consent of caregivers between August 2022 to August 2024. Their rectal swabs were collected and tested by standard culture method and Tuckman array card, TAC-qPCR, for Shigella detection. The study was approved by the University of Science, Techniques and Technologies of Bamako Ethics Committee. So for this study, the cohort characteristics are, we have a total number of 118 samples from 59 cases and 59 controls. Cases were Shigella positive by culture or TAC. Controls were Shigella negative by culture and TAC. And Cases and controls were matched for date of birth within 1 month and sex. Controls may have had other bacterial infection. The age ranges between 12 to 24 months. We have 66 males and 52 females. So for sample sequencing, we will characterize the gut microbiome communities by 16S rRNA gene targeted amplicon sequencing using nanopore platform. Archived total nucleic acid samples extracted from rectal swabs will be used. And we'll use epitomy, nanopore, and BACH bioinformatic analysis tool to do the analysis of the output data after sequencing. So this is the sequencing workflow under nanopore platform. The extraction was done using QIAM-QIAGEN DNA toolkit, and the DNA quantification and quality checks were also done using qubits and the tape station. Library preparation is done using 16S barcoding 24 that allows multiplexing of 24 samples in one go. So the sequencing is a full read sequencing, the whole length of the 16S with a nanopore platform, though other platforms, the sequencing is the short read ones. So this is just a photo of how sequencing is happening, and we use MiniNo. Flow cell is where we put the sample, the library that is prepared, and we put it in MiniNo. And the MiniNo is connected to the computer or the laptop where we have the software that does the analysis. So once we get out the output data, which is in FASTQ format file, we put it through the analysis tools, which is epitomy or BACH. So through epitomy, the tax that we expect is from the kingdom to the genus level. And through BACH, it is from the kingdom up to the species level. So progress so far, optimization of the assay has commenced with positive and negative control. So positive control is a microbial community DNA standard, and it is composed of 8 defined bacterial DNA. And we also have the negative controls that are used during extraction. And the positive control allows for benchmarking and validation of sequencing workflow. So far we've tested 22 samples that are currently undergoing bioinformatic analysis, and another 22 are currently running sequencing. So here we just want to present to you the microbial relative abundance of results of the assay optimization with the microbial community DNA standard. So on the left, the organisms, the 8 are listed, and right after it, we have the more community expected relative abundance. In the middle, we have the output from epitomy, and on the right, we have the output from BACH. So for Escherichia coli, the expected relative abundance is 10.1. And through the epitomy, we had 6.9. And through BACH, we have 20.2. So there is that variation. For epitomy, there is underestimation. For BACH, there is overestimation. And for this, we think it is because epitomy is able to also assign a taxa for Shigella, the genus level. And we know Shigella is in the lineage of E. coli. While we don't have Shigella as part of the mock community, It is not one of the bacteria there. And then for lactobacillus, the expected for more communities 18.4, and through the epitome, we have 4.8, and through WACh, we have 5.4. So both epitome and WACh seem to be more or less the same, except that they are very low from the expected. And also under epitome, we have Shigella being assigned, which is not part of the standard. So this is just an illustration of the relative abundance there in the bar graph. And if you can see for E. coli, which is orange, when we look at the theoretical one, compare it to epitome and WACh, whatever I indicated earlier is what is being reflected. With WACh, it is high. And with the WACh, with epitome, it is low. And also when we look at lactobacillus, which is blue in color, on the theoretical, the expected standard, it is high, while epitome and WACh has it low. Though the rest of the other bacteria are more or less the same. So we continue with this optimization. So for the project timeline for M1 that I've just talked about, we expect to complete processing samples by end of June. And then data analysis and this taxonomic assignment and association with disease will also commence in June to August. Then data presentation manuscript between August to November. Then we have M2, where we need to characterize the functional consequences of diarrhea caused by Shigella compared to other pathogens. And this one, selection and sipping of samples to CVD Baltimore, has commenced in May, June, and then processing will happen between July to September, and then data analysis and association with disease will also happen from September to November. So for future direction, for the data that we are currently generating by testing, we will analyze the differences between the sequence profiles of cases and controls to correlate microbiome profile with incidence of Shigella infection. And then we will characterize the functional consequences of diarrhea caused by Shigella compared to other pathogens. We hope our work will provide a deep understanding of the microbiome and the potential targets for intervention for children with Shigella. I would like to acknowledge all that are listed here for their support. And thank you for listening.
Much, Jane. Wonderful presentation. So we'll go ahead and have a Q&A session now with all the presenters. And I wanted to start, there's a couple questions in the chat. So maybe we can kick off with those. And then we request that you, if you're online, please raise your hand. And if you'd like to ask a question, and we'll allow you to ask it. So the question from Karen in the chat, I believe this is for Maureen, asked, do you have any sense of the doses that were given and whether overdoing could be an issue when treatment is unsupervised?
I was not able to get the dosages that were given, but from the discussions with the caregivers, there was a question that I would ask them if they gave an antibiotic, how were they giving the antibiotic? So some of them would say, I just gave my child after the symptoms stopped, then I stopped, or I just got a few tablets from my neighbor and I gave them those few tablets and did not finish the full dosage. So I think there was a bit of a lack of knowledge on the exact dosage that they were supposed to be giving, and also the duration as well.
The next question in the chat is for Jane. About about I wonder if there was microbial sensitivity mapping for the same study. Would it give a complete picture? Question for Jane.
Sorry, I did not.
Yeah, it's also typed in the chat if it's easier for you to see it, Jane.
Maybe that was microbial sensitivity mapping for this same study. Okay, is the question about microbial sensitivity mapping? Is it?
Yes.
No, the question is not clear to me.
Maybe we can ask the person who asked that to verbalize. Oh, perhaps they had to drop. Oh, nope.
Sorry, that is for it was a question for the first presenter. I think that's Maureen.
For Naveed then, right? All right, Naveed, do you have a response for that?
So I wonder, I did not conduct this microbial sensitivity mapping. Question is not clear to me either. So sorry.
Do you mean like susceptibility patterns of Shigella, or is microbial sensitivity?
Yeah.
something
That
else?
is for Maureen study. Yes. So like sensitivity for Shigella.
Yes, thank you. We did do that in the main EFGH study. We have about 900 Shigella isolates from the 7 sites, and we have tested all of those phenotypically. And as you might imagine, resistance is really high to a lot of antibiotics, higher in the South Asia sites like Pakistan and Bangladesh, but still substantial in many of the Africa sites. So that data is forthcoming. But it's a really good question and is really relevant to these presentations as well. Together, maybe that can really make the case for why Shigella should be a priority. So thanks for asking that.
Thank you. Okay.
Thank you. It looks like Kirk has a question.
Yeah, thanks. And thanks everyone for wonderful presentations. They're really great. Really a pleasure to watch. My question is for Naveed. I was really struck by your observation that policymakers said that Shigella is not very severe and is self-limiting, which is obviously, as you highlighted, quite a big barrier to us being able to implement a Shigella vaccine. So I'm wondering if you could tell us a little bit about the role that EFGH might be able to play in kind of spreading the words about Shigella, and maybe even if you're able to share any plans that you have in Pakistan for sharing those results with policymakers.
Yeah, thank you, Kirk, for this question. It is really a great question. So after the interviews, I really interacted with these stakeholders. I recently conducted an interview with an EPI folk, and she was very adamant, and she was very because she was a practicing physician, pediatrician as well, and she said, I really rarely see Shigella in my practice, and it is self-limiting, and it is not an issue in our setting. But after the interview, I got to involved in a discussion that I said, we have conducted this study, we have this pattern, AMR patterns, we have the serotype group which are prevalent in our population. So we will be able to share those results with you, and we will be coming with the evidence, crude evidence, to convince you for the vaccine. So yeah, this is the background story. Yeah. Over.
Thanks, Naveed. Annette?
Yeah, hi. Thank you so much for these presentations. Really nice work. I had one question related to the first presentation and one related to the last, or maybe it's a little bit more broad of a question. The first part is in terms of policy making, and maybe this goes to others in the room. Is there a plan to start looking at the potential cost effectiveness of introducing a vaccine as another key message for decision makers? That's one question. The other question is, I was curious about the sampling of young children and how easy or difficult that is, and to what kind of proficiency is required to take those samples. I was just curious about that.
So yeah, thank you. Maybe I can go first. So thank you for this question. If it was for me as a first presenter. So as part of EFGH, we have been conducting this costing of this Shigella diarrhea, but not the cost effectiveness. But yeah, as part of phase C, we may think of about conducting these cost-effective analysis on Shigella vaccines and others. So yeah, but not for as part of my project as Rising Star, I did not conducted this cost-effective analysis. Maybe over to Patty to answer the second question. Thank you.
Yeah, it's a really good point. And as Naveed said, we've strategically kind of done this sequentially. First, we've collected cost data from EFGH, so we can directly estimate the cost of Shigella attributable diarrhea. And that the idea is now we have this next 2 years of funding to answer other important questions and engage policymakers in what would make them excited about an eventual Shigella vaccine. And as you're alluding to, a cost effectiveness analysis is really going to be critical. I think a barrier for us is we don't have any data yet on the efficacy of Shigella vaccines. Like this phase 3 trial is yet to be done. Shigella has a lot of serotypes and subserotypes, and the vaccine will, be hopefully 4 of those subserotypes and serogroups. So we don't know, is that vaccine going to have efficacy and cross protection against all the serotypes or just that 4? And so this cost effectiveness analysis, it's going to be crude because there's going to be a lot of assumptions made. So I think we'll do the best we can with the data we have, but like a lot of modeling studies, it'll definitely be limited. But thank you for raising that point. To your second question about the sampling, I think you're referring to the stool collection and the rectal swab collection. I wonder if those of you in the group would be willing to share on that. I know you all had experience taking the samples yourself and coordinating the team that took the samples. And rectal swabs was our primary sample, not whole stool. Would anybody be willing to comment on that? Maybe I could call on Maureen.
Hi, Patty. I'm not sure I got your question. Well, may you please repeat?
Yeah. How hard was it to get rectal swab samples from children enrolled in EFGH? In the planning phase of EFGH, we knew we needed a stool sample. We decided about using rectal swabs instead of whole stool because we wanted to get the sample before any antibiotics were used. Some people were concerned rectal swabs would be difficult to collect. In your experience in Malawi, how difficult was it to collect rectal swabs?
So in Malawi, it wasn't very difficult. It was okay with the rectal swabs. But when it came to collecting host stool, we had a bit of a challenge with collecting host stool because some of the children would not produce stool while at the clinic. So later, I think we had to do a protocol amendment and say that would collect the whole stool at home. So a mother was given a stool bottle, and they would call us when the child has produced stool, and then our field workers would go and collect the whole stool. So yeah, for the rectal swabs, it was quite easy, but whole stool was a bit of a challenge.
Thanks, Maureen. And just one point is one of our data pieces that we'll have is a non-inferiority analysis to compare the culturability of Shigella between whole stool and rectal swab so that people can feel like rectal swab is a good enough sample. We have time.
I'm sorry, these are hopefully quick questions. I heard bits of all of these, but for the last presenter, I noticed that the epi-to-me, you have Shigella as one of the things you're probing for. So wouldn't by default the microbiome look different when you're using that test to compare the effect of Shigella versus in the cases versus controls? So that was one question. And the second was for the first presenter, just big picture. We see so much pushback after the COVID vaccine and a lot of rumors and misinformation. I was only able to join near the latter part of your presentation, so you might have talked about this. I was curious in your context, is there a reaction with vaccine distrust after COVID in your context and how that affects the Shigella vaccine? And for Maureen, I was just curious why metronidazole is so popular.
Okay, so
Maybe we could do Jane and then Naveed and then Maureen.
okay, for the question about epi-to-me, because I'm also just started learning about this bioinformatics, I would like to defer this to my mentor who is in the call, Alba Dagmar. Could you please help respond to this?
Yeah.
Dagmar, Alba. Yeah, she's here. Oh, she does not have a button to talk.
Oh, shoot.
Okay.
She can speak, but she's not muted.
It's unmuted now.
It's unmuted. Can you try to respond, please?
Okay, excellent. And so epi-to-me is the software that comes with the Oxford Nanopore platform. And the way they are actually looking at, so Shigella and E. coli is very, very similar. So when you look at D16S gene, there's only a few SNPs which are different. So what epi-to-me does is they blast it against the database, and basically whatever comes out first, they call it this. So if Shigella comes up in the list first, and there's the second one would be E. coli, the third one would be E. coli, they just call it Shigella. So that's sort of a little bit of a problem with that platform. So the other platform, we have an in-house pipeline, and I think Jane will be trying that as well. But it will generally be difficult to distinguish between the two. WACh does it slightly differently, so they form clusters. So they say anything that looks very similar, they put into a cluster, and then blast this cluster against a database, their own database, and then they can say this is E. coli or this is Shigella. But we have been speaking with them, and they are also saying because they are so similar, it will be difficult to distinguish between them. And Nanopore still has quite a large error rate in sequencing. It's much higher than Illumina, for example. But you can now reanalyze your data, and it's called super high accuracy base calling. And with that, we should hopefully be able to distinguish between Shigella and E. coli. So that's something Jane will try next. Did that answer the question?
Yeah. The next question was for you, Naveed. Vaccine hesitancy in Pakistan. Yeah, go ahead.
Yeah, thank you so much for this. This is a very pertinent question in context of Pakistan. So COVID has brought so many controversies, but with the passage of time, this API program has adopted so many strategies to overcome this hesitancy, and they have a separate department who deals with the hesitancy rising from social media, from the other groups as well. So we have been, apart from COVID vaccine, we have been facing issues with polio vaccine as well. So they have strategized, and they have come up with the plan, and they have invested a lot on communication strategies and to overcome this issue. And so I was surprised to know that, during the interviews, that they say we have this separate department who deals with these issues nowadays. So we don't face any issues anymore. But in pockets, we still face so many issues of hesitancy, but not very large. So yeah, this is the situation. Over.
Thanks, Naveed. And last but not least, Maureen, why metronidazole over all the other options?
So I would think because it's prescribed a lot by the clinicians. So I remember when we started EFGH the first year, because the participants were being recruited after passing through the MOH clinic. When they come to the clinic, we would note that in their health passport, they would have been prescribed an antibiotic and zinc or ORS. But our clinicians at the EFGH clinic would only prescribe ORS and zinc. So there was a bit of, I think there was a bit of misunderstanding with the MOH team as to why we're not giving antibiotics. And I think and eventually we had to do a training with the clinicians and in terms of the treatment guidelines, the recommended treatment guidelines for diarrhea, that not every diarrhea should be given an antibiotic. And I think after that, it sort of helped. And so I think from the caregivers, because they're used to giving an antibiotic, especially metronidazole, when they see that their child has diarrhea, then they'll go ahead and give them metronidazole, or a neighbor will give them metronidazole because it's what they've been getting from the health facility.
Thank you so much. I think we have to wrap up. It's okay if I give. Yeah, what a pleasure, especially for me, to have 75 minutes of Shigella focused talk. This is a dream come true. They were all wonderful talks. Thank you all so much. Thank you to everybody who supports the Rising Star program. Thank you to all of you speakers and your mentorship teams. This was truly incredible, and this meeting has been recorded and we'll be sure to share it widely. Thanks for the great work, and thanks to the listeners. Bye-bye.
Thank you.
Thank you.
Bye-bye.
Bye.
Thank you.